Okay, thank you very much. So we're moving down the clavicle to the AC joint now. My disclosures are on the website. So, AC joint injuries. I think everyone knows about the Rockwood classification. One of the most important things I want to highlight is that type 3 is still less than 100% displaced, and type 5 is over 100% displaced. I still see this misquoted where people think type 3 is over 100. It's not. 3 is actually less than 100. 5 is over 100% displaced, and type 4 is posteriorly displaced. Type 6, I don't think many people have seen a type 6 that survived, so these are pretty high energy injuries, and patient is usually pretty traumatized and a lot of times doesn't survive. So again, classification system type 3 is up to 100, type 5 is over 100, and it becomes important when we speak about selection for surgical fixation. Type 1 basically has normal radiographs. Type 2 has a little bit of displacement, under 25%. So how do you get good radiographs? Well, you need a Zanka view, an upshot to look at the AC joint. And it's really helpful if you can include both clavicles so you can see both AC joints and compare one side to the other. It just gives you a frame of reference. And what you really want to look at is the CC distance, or the coracoclavicular distance. I don't know if this, oh, there you go, pointer. So here's the coracoid, there's the clavicle. So this is your CC distance on the normal side, and there's your CC distance in the abnormal side. And you can see what the CC distance here is way more displaced than the other side. So it kind of gives you a reference to see how displaced one is compared to the other. When do you fix these injuries? Well, there was a randomized controlled trial done by the Canadian Orthopedic Trauma Society. They looked at type 3, 4, and 5s and randomized them. Half received surgery, half were treated non-operatively. And they used a hook plate to fix these, and they followed the patients up for 2 years. Their primary outcome was DASH score, so that's a disability score, so patient functional outcome score. What were the results? Well, they actually showed that surgery had more disability early on, and by about 6 months, it was pretty much the same. Even 2 years out, they were the same. So counterintuitively, surgery actually did worse initially because they had an operation. They probably had more pain. And then by 6 months, they were pretty much the same. So it didn't seem to improve outcomes. What about the constant score? Well, again, same thing. Surgery actually had lower constant scores initially, and by 2 years, they were the same. So I think what this study highlighted was that non-operative treatment actually has decent outcomes. So it's hard to make patients better, at least in this study, with surgical fixation when it comes to functional outcome scores. They did look at some other outcomes, for example, radiographic assessment. So radiographically, obviously the clavicle was in a better place, the AC joint looked better reduced with surgery compared to non-operative treatment. So that was a good thing. There's been other studies looking at this. This was a meta-analysis looking at 19 studies. Again, surgery had better cosmesis, better radiographic outcomes. This one meta-analysis said better constant scores, but it was only 3 points. So it didn't even, it wasn't even clinically significant, didn't meet the MCID. Non-operative, faster return to work, lower implant complications, and lower infection. And there was really no difference in terms of DASH or return to sport. So this study, again, highlights the same thing, that non-operatively, patients seem to do okay, and it's hard for surgery to make a functional improvement. It makes the x-rays look better, but are we really helping the patients? Again, this is just a forest plot illustrating the same thing. So if you look at the constant scores, it was a little bit better, but again, it was only 3 points out of 100, didn't meet MCID. And when you look at return to work, it actually offered non-operative treatments because patient can return to work much earlier, as you saw in these, the first graphs I showed you, to have less pain and disability, hence they can go back to work earlier. So when is surgery indicated? I think we still don't really know, frankly. I think a lot of people are still operating on young, active, healthy individuals with a severely displaced AC joint, so maybe a grade 5. If it's open or impending open or polytrauma, and if it's an elderly or anyone with risk factors, drugs, alcohol, non-compliance, then you should definitely consider non-operative treatment. So I think we still need to work out the indications and who would potentially benefit with surgery in this type of injury. So we're going to focus on this. Let's say this is a type 5. It's severely displaced in a young active person. How would you treat this surgically if you were going to? And you'll get patients who are definitely unhappy. So I'm not saying everyone's happy with non-operative treatment. There's certainly patients who come back and they're very unhappy. It's just hard to tease out who those people are going to be early on. So that's the issue. But let's say we have this terribly displaced injury and patient wants surgery. How do we fix it? So one option is a hook plate. And the other option is some kind of suture fixation, like a tightrope. So this is how you apply the hook plate. Here it is displaced. You put the hook plate on, reduces the injury. Most of these have to be removed. Some people don't have any impingement symptoms. Again, the hook is a lot posterior than you would think. So when you look at an X-ray, you think, how does that not impinge? But the hook is actually pretty posterior. So I do have patients who come back, they have full motion, they have no impingement. They're not interested in any revision surgery, and I leave it in. But I would say about 50% of patients at least, we do take it out. There are complications with the hook plate, so you can get an over-reduction. We'll talk about that. You can get erosion through the acromion, and hardware does need to be removed, so that is an issue to consider. So you want to avoid over-reduction if you're using a hook plate, which is a major issue. So here's an example of a type 5 displaced. You can see that the CC distance is quite increased, 19 millimeters compared to the normal, which is 9. Most people are around 9 to 11 millimeters for their CC distance. So this person underwent surgery. This clavicle is over-reduced. The other side was 9 millimeters, so you want to aim to match the other side. This one is way over-reduced. You can see that if you follow the curve of the distal clavicle, here's the distal clavicle, and there's the acromion over there. So this is way over-reduced. And this hook is a previous iteration of the hook plates. You can see how it's 90 degrees and it's point loading right here. It's not contoured well to fit underneath the acromion. So I don't think it's a surprise that this clavicle sprung back up, and it's actually in a happy place now because the other side was 9 millimeters. So it actually went back to where you should have put it. So if you don't over-reduce it, then you decrease the risk of this failing. So these are the newer generation hook plates. This is just one example. You can see how it's not 90 degrees anymore. It's angled to match the undersurface of the acromion, so it doesn't point load and it sits nicer. And there's different depths. There's different depths of the hook to match the patient's anatomy. So a lot of times I might put based on patient anatomy, I might put the medium depth in, get an X-ray of the other side and this side, compare. If I'm over-reduced or under-reduced, then I might change to a narrower depth or wider depth. So what about tightrope or suture fixation? Well, it has a lot of issues on its own as well. Here's one study looking at radiographic displacement of AC joints after tightrope fixation, and about 1/3 of them have displacement post-op. That's a pretty high number, 1/3 of them. So 19% had partial loss of reduction. About 10% had complete failure. So those aren't great numbers. There's other studies looking at complications of tightrope. This one reported hardware irritation. You can actually get fractures of the coracoid. And again, loss of reduction, 27%. So even this study also reports 1/3 that lost reduction. And if we go back, I want to highlight this one. Hardware migration, so up to 89%. So a lot of times people actually over-reduce the clavicle when they use a tightrope because they know most of the time it's going to displace. So they over-reduce it to compensate because they know it's going to displace somewhat to hopefully reach a baseline. So there's definitely issues with the tightrope as well. So in summary, patient selection is key. I think we still don't really understand who those bad actors are, and it's important when you're considering surgery or not, take it into account patient factors like activity level. Are they overhead active type of person, manual laborer, young, active? If they're diabetic or smoker, drugs, alcohol, no, non-operative treatment. And then in terms of fixation, your options are hook plate and tightrope. They each have their issues, so kind of pick the one you're most comfortable with. Thank you very much.